Hello, welcome everybody. I'm P.S. Martin with the WVU Division of Pre-Hospital Medicine. I'm assisted today by Dr. Michael Shukas, who's one of our fellow EMS physicians. The presentation today is basically to cover supraglottic airways. Up to this point, you have used the combi tube, possibly at one time, and the King airway. We're giving you another option, which has recently been approved, and that's the iGel. We as a group don't have a preference of one over the other, but what we want to do with this presentation is impress upon you the fact that these airways, when used appropriately, work, and they do a good job. When used inappropriately, they can actually kill a patient. So you've got to be extremely careful with them. The two airways, again, that we're covering and that have been approved in the state are the King and the iGel. The biggest difference, again, is the stiffness of the two devices. To demonstrate, again, the King airway, pushing against my hand, very, very stiff. This can perforate the esophagus and be deadly to a patient. The iGel is extremely malleable and fits into the airway very, very well. Both have their positive and negative points, and I'll be covering those briefly in a lecture. And then we'll also go over those points again with a demonstration of how to insert them. This is a brief presentation on extraglottic airway devices and potential misplacement. There's been a timely article which has occurred in Annals of Emergency Medicine in the past couple of months. It's a very interesting study for us. Sort of what they were looking at isn't exactly helpful to us, but some of their findings are extremely helpful for us. The title of this was Extraglottic Airway Device Misplacement, and they were actually looking at a novel classification system of how to classify these misplacements. And it's kind of interesting the way they did it. This study was a post-mortem study. It was done actually in New Mexico. So a very rural state, in all honesty. It has some decent-sized cities, but overall it's a very rural state and has a fairly similar population to what we experience. Things are a little different there, as you'll see as I go through the presentation itself. But what they did was they pretty much everyone who goes to the medical examiner there gets a CT scan, interestingly enough. Especially post-arrest patients get a CT scan so they can actually look at them before they touch any of the devices or any of the tubes that are in them. They leave everything in place, they do the CAT scan, they look and see what becomes of it. So the study centered around extraglottic airways and the placement of those and possible misplacement. So we know that extraglottic airways are as effective as intubation in the initial resuscitation of patients. And we know there are two classes, essentially. There's the supraglottic and the retroglottic. Examples of the supraglottic are the LMA, which you can see here, and I believe this is an ambu. This is another supraglottic airway called the Cobra. It's kind of frightening, actually, to me, but it's an interesting type airway. These are essentially masks that fit over the glottic opening. Another supraglottic airway is the iGel, and that's one that's been recently approved by the MPCC for us to use in West Virginia. And this is an example of the iGel airway in place. Again, it's a laryngeal mask. It's a little mask that fits over the glottic opening. Placement, which we will demonstrate later, is basically with the head in a sniffing position. If the patient is a trauma patient, you use a modified jaw thrust, and then you place the tip of it, well lubricated as usual with any supraglottic airway. Place the tip along the roof of the mouth, down into place. As you pass the tonsillar pillars, you sort of feel it give way a little bit, and then you push down until you meet some definitive resistance. Once you meet that resistance, you don't go any further. Keep in mind all of these also are a blind insertion, and that's why they're so good at resuscitation, because you can quickly place them. As you can see with this one in place, and a little bit of pressure applied to it, it forms a nice seal around the glottic opening. When ventilating through this airway, you want to ventilate just enough, as you should with any supraglottic airway. You want to ventilate just enough to let the chest rise and fall. Any excess ventilation on that airway will push the mask away from the glottic opening and you'll lose your seal. So it's just enough to let the chest rise and fall. Don't overdo it. This airway also has a place for a gastric tube to go down that comes out the tip here and goes down into the esophagus to drain the stomach. So that's an example of the iGel. The retroglottic airways, some of you are familiar with the combi tube, which isn't necessarily used that much anymore. And then the one that you're most familiar with is the King Airway. The King Airway itself, as we will demonstrate to you, again, is a blind insertion, well lubricated. It's a very stiff tube, and you need to make sure that you're not pushing against any resistance. You definitely do not want to force this airway. The difference between this and the iGel is that the iGel does not have a cuff that needs to be inflated. The King Airway has two cuffs that are inflated through the same port. One of the problems with the King Airway itself is the fact that these cuffs are weak sometimes, and they can tear easily, especially against teeth or damaged teeth, bones, anything along those lines can cause perforation. And if this cuff does not hold air, this airway needs to come out, because both of those cuffs have to be inflated for there to be a seal to appropriately ventilate the patient. As an aside here, just to demonstrate the angle in which these airways go into when they're truly in the patient, you can actually see the abrupt turn that this takes and how it pretty much bends tightly here and then levels out. Both companies and several educators over the years have made the statement that we could potentially intubate someone by placing a bougie through this airway and getting it into the airway and placing it, then pulling out the King and placing an endotracheal tube over it. In this case, I'll be honest with you, once you get the airway in this position, the bougie cannot make that angle to exit the entrance of the glottic opening. And even if it could, it would come up and hit the front of the trachea and not give you a direct path to get the endotracheal tube into the trachea itself. So this is not a good plan. This is not a good thing to do. The same situation comes up with the placement of the supraglottic airway, the LMA. You have a wider opening to place the bougie, but again, this abrupt angle stops you from getting the bougie into the patient's glottic opening. And even if you did happen to get it into the glottic opening, the end of your bougie is going to hit the front of the trachea here and not allow you to place the endotracheal tube further down into the trachea where it needs to be. So in my opinion, in our opinion, this is not a good concept and not something that you should do. So some known issues with the supraglottic airways, again, as I mentioned, it's a blind insertion. That can be an issue. It can be great for us because it's done quickly, much quicker than endotracheal intubation, and can allow you to get an airway somewhat secured to proceed with your resuscitation. A problem with the blind insertion is that you got to make sure you're in the right place and that it's functioning well. There have been multiple reports of misplaced or dysfunctional status of these tubes once they have been put in place. That's why you've got to monitor them. Every supraglottic airway, just as in every endotracheal tube in the field that we were working with, needs to have continuous end-tidal CO2 monitoring. That's the only way you can make certain that that airway has not moved and that you're appropriately ventilating the patient. These can definitely cause injuries as well, as you'll see shortly as I proceed through. One study by Villathani and his group basically was a retrospective study looking at the King LT airway itself. And they looked at 344 placements, and they found a misplacement rate of about 14%. And I just want you to remember that number, that 14%, because that's going to come back to visit us shortly. So when this group of people got together and they developed their classification system, they found there were 6 components. The 6 components were depth, so being at the appropriate depth, because these either have to be a mask that covers the glottic opening, or they have to have openings that are just below the glottic opening at the appropriate depth to be able to ventilate the patient. If they're not at the right spot, then you can't appropriately ventilate the patient. Size, again, that size of the device allows you to get the appropriate seal and allows you to have those openings in the right place to be able to ventilate the patient. Rotation, these devices, especially the King airways or the retroglottics, can't be rotated too much to one side or the other, because if they are, then those holes where the air is coming out of could be up against soft tissue and not allowing you to ventilate the patient. So again, rotation is not a good thing. Device kinking is not a good thing. As you've seen in the earlier pictures, those devices take a pretty sharp angle, actually, as they go into place, and that sharp angle can kink off the tube and not allow you to ventilate right, but can also preclude you from placing the gastric tube, which allows you to drain the stomach contents to help prevent any aspiration. And then mechanical blockage, and with mechanical blockage, it's typically food products. And under that mechanical blockage, I want to stress to you right now, anytime you see a supraglottic airway that has vomitus in it, that airway must come out. You need to get that airway out, because if the airway itself is caked in vomitus, that means that the area below the glottic opening likely also has vomitus in it. So you need to remove that airway, suction the airway well, either clean that airway off very well or replace it with a new one so that you don't have that chance of aspiration. And then injury, looking, did we cause any perforations? Did we cause any tearing or bleeding? Remembering also that many of our patients are on blood thinners, and any trauma to that airway can certainly make things very, very difficult for the person trying to intubate them later or replace this airway with an endotracheal tube. They defined definite displacement as an airway that needed to be repositioned to be able to function, essentially. And looking at this study, they found that there was misplacement requiring repositioning for that function to occur in about 14%. So that number 14 comes back to haunt us. So keep that in mind again. So 14% of these airways placed are malpositioned to the point where they need to be repositioned to function. So the main results overall, inappropriate depth was present in about 11.7%. Most of those were shallow but still ventilating, so not a major issue there. 7.3%, the tip of the airway was actually in the mouth. So with the tip of the airway being in the mouth, there's no way you can have a seal and appropriately ventilate that patient. And then only 0.6% were too deep. Size was an issue on only 2.3%, and typically it was too large or the cuff was overinflated. Nothing was too small. Okay. Rotation was present, and again, rotation was defined as greater than 30 degrees because that would put the airway in a position where it wasn't going to be able to ventilate well, and that was found in 2.1% of the cases. When it came to kinking, we had 2.6% had major kinking, and again, 62.5% of those had the tip in the mouth, which means the airway could not function. Mechanical blockage in about 2.3%, and those were large food boluses. Again, if you see vomitus or food anywhere in part of that airway, it needs to come out. You need to clean that airway, suction it well, and replace it with a clean airway, or at least get that original airway cleaned off well. Injury was found in about 6.2% of the cases. 4.7% were minor, 1.5% major. There were 3 perforations, 2 of them pharyngeal and 1 esophageal. Interestingly enough, remember, king airways amounted to less than 4% of the airways evaluated in the study. However, they accounted for 100% of the perforations found on postmortem CTs. This is an example of that esophageal perforation, and this is a king airway. And I'll demonstrate to you, this is basically the oropharynx, okay? And this is the tip protruding from the oropharynx to the esophagus through the soft tissue, and it's actually in the mediastinum. So your airway is here, your glottic opening is here, and the tip of, which you'll recognize that tip if you've seen the king airway up closely, is actually sticking in the top of the left mediastinum. So it has completely perforated the esophagus on this patient. Again, all the reason to make sure that we're lubricating these devices very, very well. So the applicable findings for us, the findings that really mean the most to us, keep in mind that nearly 1 in 6 of these devices that was placed was misplaced. So there's a problem in 1 in 6. So I've stressed to you, we don't have a preference of one over the other. Both will work perfectly fine if they're used appropriately. If they're not used appropriately, clearly you can see you could harm a patient severely. So more needs to be known about the frequency and the type of these misplacements. The 6-component classification system, I think, while it's interesting, I don't think that it really helps us that much other than helping to understand the mechanisms of how devices can be misplaced. And that's probably the most help I get from that. The biggest lesson for us is to keep a high index of suspicion for misplacement or complication of these airways. Make sure you are monitoring them continuously. Make sure you have good compliance with bagging, that you have good end-tidal CO2, and that you are not hearing air leaks. Because if you are hearing air leaks, that means you do not have a seal. And if it's the eye gel, it needs to be repositioned to where the point where you're getting a good seal and you're not over-ventilating to the point where you're pushing the mask away. If you hear an air leak with the King Airway, you've got to check that pilot balloon immediately. And if it's not holding air, then make sure you add air. Again, if it's not holding, then you need to reposition that because or actually replace it, because there's a good chance that that airway or that cuff is damaged. So mitigation and conclusions for you. I think we need more widespread use of capnography, and I can't stress that enough to you. One thing that was recommended to consider as possible video laryngoscope or direct laryngoscope use during placement of the glottic airway. The problem I have with that is that we lose the ability to quickly gain access and to manage that airway. The whole reason why we are happy about the blind insertion and the use of these airways is quick placement and quick management of the airway. And if you're pulling out the video laryngoscope or the direct laryngoscope, you might as well just intubate the patient if you can. That's my point with it. Make sure you never have any forceful insertion, and everything has to be lubricated. Time and time again, I have seen King Airways placed by EMS personnel without any lubrication on them. And I hope we've demonstrated to you exactly how stiff these airways are and how much damage they can truly cause if you force them and they're not lubricated. Foreign body, mainly, foreign bodies in the airway are food material. Again, I can't stress enough. Any vomitus, any food material, clean that airway out, replace that airway. I think training and device types and different patient characteristics need to be involved in our management and in our training of you folks. So hopefully in our discussion today and in our demonstrations today, we'll be able to get those points through to you. Again, maintaining that high index of suspicion of any possible misplacement or any possible trauma related to the placement of this. And clearly we need more prospective observational studies using different airways to see what is best and how to best mitigate these factors or changes.
First, I want to show you a chart that shows just the basic sizing on the King Airway for you to review. This is, again, just going over the size of a King Airway is based off the height of the patient. Most patients are going to be between 5 and 6 feet tall, so you're going to be looking for the red cap on the King Airway. For the mannequin and what you're going to see going forward, he happens to be sized for a 6 foot tall person. So you'll see that I'm going to use the purple device. So next I want to show you the anatomy of how the airway is inserted and to get a better appreciation for where it seats in the airway. So a little bit of anatomy. This is the tongue here, the base of the tongue. The epiglottis is right back here. And then the arytenoids are the two little bumps back here. That's the posterior most portion of the airway. Just behind that is your esophagus. So when you place your King Airway, it's actually intentionally going to go into the esophagus. And the bigger balloon rests directly at the base of the tongue. When you inflate the device, you can see that the balloon ends up blocking the base of the tongue and doesn't allow for air to escape out the top, out the mouth. And then I'm going to turn over to the side here and show you. Down the esophagus here, the second balloon is occluding it from going into the stomach. This allows for the air to go out, around, and then down through the vocal cords and down into the lungs to ventilate the patient. Now that we've gone over the appropriate sizing for the King Airway and shown you how the device can be placed using the physiologic model, we're going to show you the appropriate steps to inserting the King Airway device. First, you make sure that you're appropriately positioning the patient. They should be in a neutral position or potentially with a slightly elevated head in a sniffing position. The next step is to make sure that, again, you have the correct size King Airway. In this case, this is a mannequin that's supposed to be 6+ feet tall, so the purple airway here is the appropriate one to use. And on the side of this device is the amount of volume that you're going to be putting into the King Airway, so make sure you make note of that beforehand as reference. In this case, with it being a purple device, it's going to be between 70 and 90 mLs. Once we're ready to insert the King Airway, the first thing you're going to do is lubricate the tip of the device. So just putting a small amount of lube on the back of the device here, not getting it into the airway portion down here, should be enough to allow for smooth passage of the device itself. In order to open the mouth, it's usually easiest to insert your thumb onto the tongue to push the tongue down and to bring the jaw down slightly to avoid having the cuff get torn on the teeth. You then gently insert until you meet resistance, which should be at just about the same depth as the last mark on the King Airway device itself. Once you're in appropriate position, you're going to inflate to the smaller of the two numbers, in this case 70 mLs. So with this syringe, I'm going to have to insert an extra 20 since this is a 50 cc syringe. And you're going to attach your BVM to the device. Once you have this, you should feel that it is hard to inflate the device. This means that it is slightly deep, and you're going to slowly back out the device until you get good compliance. Once you have good compliance, the next step is to confirm that you have an appropriate airway and that confirm that it's appropriately placed. There's several ways to do this. The first and the easiest is to listen over both lungs as well as the epigastrum. So I'm going to hand this off to my imaginary partner here to keep ventilating. And while we're here, we listen to both lung sounds to confirm that we can hear it on both sides, as well as it is absent over the epigastrum. In this case, that's appropriate. We can see chest rise and fall as we're ventilating, so we know that we have the King Airway in appropriate position. The other way to confirm that we're in the appropriate position here is while we have everything secured and I'm holding onto the tube, you should also have an end tidal device in place, as well as a viral filter to make sure that we're not sending contaminants into the air. This end tidal gets hooked up to your monitor in order to confirm appropriate waveform and number for the end tidal device to make sure that you still have an airway. This should stay on the patient all the way to the time of transfer. You should make note of what the end tidal number is on your cot before you transfer the patient, and again when you have transferred the patient, or for any other maneuvers that occur while you're out in the field, to make sure that you haven't dislodged the airway at any point during the movement process. Once we have this device in appropriate depth and we've been holding it in correct position and ventilating the patient the whole time, the next step is to secure the airway. So once you're going to secure the tube, you can do this one of two ways. One is to use a Thomas tube holder or a similar device, a commercial device that allows for a piece of plastic to hold the tube in place and a bite block to keep them from biting down on the tube itself. The other way to secure the device is not ideal but is also appropriate, is to use tape. You can split a wide piece of tape down the middle, secure to the one side of the mouth, and then wrap that tape around the tube itself in order to make sure that it does not get dislodged. If the patient is diaphoretic and the tape is coming undone, you can do an additional piece of tape along the other side of the mouth or add additional layers as you need to in order to keep the tube secured. When you're taping this, make sure that you're not occluding the port in the back of the device, as you're going to need to next insert a OG tube into the device to help decompress the stomach. This skill can be done by both ALS and BLS providers, as long as it is going through the port that is intended for either the iGel or for the King Airway. So again, I'm going to pass this off to an imaginary patient or imaginary provider to continue ventilating the patient. And just for the sake of being able to see better, move this off to the side. So in order to appropriately place the OG, you first need to be able to measure the length that you're going to insert correctly. So you start by placing it over the xiphoid process, going to the corner of the ear, and from the corner of the ear going up to the corner of the mouth. In order to place this, it's relatively simple. You can add a small amount of lubricant just to the tip of the device, and then it should go smoothly into the back port here. And you should keep your finger pinched over the depth at which you marked previously to make sure that you haven't changed the depth that you're going in. So once you've put the OG tube to the appropriate depth, you need to secure the tube in place. You can do that with another piece of tape around the back to make sure that it doesn't come undone or become any shallower or deeper than where you plan to have it. The final step is to confirm the tube is in the correct location. In order to do this, you take a Toomey tube syringe, take this connector out from the OG tube, place the syringe into this port, and auscultate over the stomach to confirm that you hear. So you should be able to hear a rush of air as you inject. So again, I want to start by showing you a sizing chart for the eye gel in order to reference before you insert the device to make sure that you have the appropriate device placed. For the eye gel, it is weight-based, not based off of the height of the patient. So for the average adult, both male and female, you're most likely going to be inserting a size 4, which is between 50 and 90 kilos. The other thing to reference on the chart is the size of the suction tubing that you should be inserting, as the hole does vary slightly as you get to smaller sizes. The final thing I want to do is show you the appropriate placement of the device on an anatomic model to get a better appreciation for where it sits in the airway. So again, looking at the airway model here, you've got the base of the tongue as well as the epiglottis, and there's a rim that goes down towards the arytenoids here. That opening between the epiglottis and the arytenoids is actually where the rim here is going to rest for the eye gel. So as you insert it, you go down the base of the tongue. It's fairly soft and malleable, and as it goes, it will rest directly into that site. I'm going to flex back just so you can see it a little better. But it rests right on top of the epiglottis and includes that portion of the airway. We're going to go over how to go through the proper steps to place an eye gel. It is very similar to the King Airway with some key differences. First is positioning is pretty much the same. You want them in a sniffing position or a neutral position to the head. The eye gel does not require that you grab the tongue to pull down on the jaw. Jaw thrust or just pulling down on the chin is appropriate, as you don't have to worry as much about tearing the cuff. In order to place the device, the eye gel actually comes with a plastic holder. In order to add lubricant to the eye gel itself, there's a very small dimple in the handle here. You place a small bead of lube directly in that location, and then glide the edges of the device along either side, as well as the back of the device along that region as well, to give a small film of lubricant. What you do not want to do is have the very tip where the suction would go through occluded, or have in around the rim here occluded with lube, as that would then go into the airway and can cause complications. One of the advantages of the eye gel is that it does in fact have on certain models a additional port that allows for apneic oxygenation. So if you have an additional port on the side here, which we do recommend getting that style, you can attach supplemental oxygen while you are doing the procedure, which will allow for an apneic patient to receive passive oxygenation throughout, even if you are not ventilating them appropriately, or there's a pause in ventilation for any reason, they're getting some oxygen even though it is not ideal. This can be hooked up to your normal oxygen canister along the side port here, and that then ventilates going down into the ET tube just like you would for the BVM. It's an additional port for oxygen. Once you have oxygen connected, the final step before you insert the device is actually to measure and partially insert your suction catheter. So you're again going to use an OG tube and measure like you did for the King Airway, going from the xiphoid process to the corner of the ear, and from the corner of the ear to the corner of the mouth. You want to make note of this depth here, either by continuing to keep your finger on there or marking with a marker or with a piece of tape so that you don't lose your depth. Once you've done that, you're going to place a very small dab of lubricant over the hole that's on the side right here. And that's going to allow for easier passage of the suction catheter down into the device, especially once it's inserted in the mouth. You're going to start by inserting this all the way down the device until it is just coming out the end and retract till it's flush with the tip here. You now should have two things attached, the oxygen and the suction, and you will have the depth to which you should ultimately insert the device also marked. At this point, you're ready to insert the device. You can press down on the jaw to allow for a little bit more motion to get the iGel in place. As you're inserting, you'll feel slight resistance. You should be able to push past that until you feel definitive resistance. There's not much pressure to start. It's very little resistance followed by definitive resistance. Once you have the iGel placed back into that position, there is no cuff to inflate on this. So the final step is to get a BVM and to start confirming the positioning of the device. So again, we're going to have a BVM that has a HEPA filter and an end-tidal CO2 attached to it to be able to confirm and also to keep the area clean so that we're not putting particles into the air. Once this is attached to the device, you should be able to ventilate, see equal chest rise and fall, and then also have either you or your partner auscultate while you are ventilating. You should also listen over the epigastrum to confirm that you do not hear gastric contents as you would with the King Airway. Once you're at this point, there is not much repositioning that needs to be done. If you need to troubleshoot, it is often making sure that the iGel rather is in midline with the patient. If you notice that it has moved off to one side or the other, that is often the reason for any difficulty with ventilating that you may have. Once you have good chest rise and fall, confirm with an end-tidal waveform again. And just as we talked about before, you should be getting a number obtained before any movement of the patient. So while on scene, before you go into the truck, or when transitioning in the hospital, you should be getting an end-tidal while on your cot, and again after they've transferred over to the ER bed to confirm that it wasn't dislodged during the movement. So I'm going to again pass this off to my imaginary provider here to continue with the ventilation, just so you can see the device a little bit better as we're doing these next few steps. So the final steps on placing the iGel are to secure the iGel in place so that it does not move. iGel comes with its own strap that allows you to do this. So you should be able to slide this underneath of their head. And then it is honestly a bit more secure to give it one wrap around and come up on the prong on the side here and then come the other way around once to the other prong, and that will give you just snug enough that it won't back off on you, and it gives you a good bit of lateral support as well. The final step, once you have this all in place, is to insert your OG tube the remainder of the depth and to confirm that it's in an appropriate position. So we're going to continue to advance the OG tube down to the mark provided by the tape. Again, just a little bit more resistance with this just due to the silicone on the mannequin. But once we're down to appropriate depth, we again confirm appropriate placement. The way to confirm appropriate placement is to again remove the football connector, use a Toomey tube syringe, and to auscultate over the stomach while you are also injecting into the syringe. When you're doing this, you should be able to hear a rush of air over the stomach to confirm that you're in an appropriate position. Once you've done that, you can take the syringe off, replace the football connector, and attach your normal oxygen suction directly to this in order to empty gastric content. This last few steps is the exact same for the King Airway once you've confirmed the device, and can continue on your normal house suction in the truck or the portable suction in their house until you can get them out to the truck.